Hold on just one more second. I want to make sure that the video and audio are good on the live stream.
We look so sober. They did a Saturday Night Live skit on this. But just before a conference call, everybody's trying to figure out how to say, do, look.
All right, you're welcome to go ahead and start policy committee.
Great. Thank you. Good morning, everybody. I'd like to begin the policy committee meeting today. We're going to start with the rule spreadsheet and schedule as the first item on our agenda. And so I'll turn over to Kim.
All right, thank you. This is just for your information on how we're doing with the rules. You know, we're making good progress while we're working from home and on working through those and you know, it continues to be a focus. So if anyone has any questions, I'm happy to answer those. Otherwise, I don't have an action item on this.
Any questions? All right, seeing none, thank you for the information, and we'll move on to the legislative update. Jonathan LaCrosse.
Morning, everybody. It's been a busy time in the legislature, so we've got a little bit to get through. I provided everyone with kind of an outline of the legislation that we're going to touch on and go through. Before I begin, a lot of bills are moving in the House and the Senate because they're getting ready to go on break here, and they're trying to clear out a lot of red lines to get them out of their chamber, and some will come back and visit in the fall. We'll see some legislation. They were not labeled as priorities for either chamber before they break. And I wanted you to be aware of that. The conversations around licensure, of course, are ongoing, especially during the time of COVID. But these two bills have not been seen yet. So we will keep you abreast on those, and I wanted you to be aware of that, that those are two pieces of legislation that are not moving. One that is, I will touch on now. We worked on this around probably before the reciprocity bills happened, was 263, which is the criminal convictions bill. This is a House bill. It's Representative Kaler's piece of legislation. This bill essentially would do is require the board to create a list of disqualifying offenses. And as you know, currently the board does not have that list of disqualifying offenses. And these would be felonies. We take each individual and look at them, look at them personally. And I believe within the past 10, 15 years or so, we've only had about 5 felonies that disqualify somebody from receiving a license. We would have to do that in this bill. Anything more than 5 years, the board will not be able to consider as well. So if that time frame has passed and there was a major felony that came across licensure, we would be able to consider that. It also would remove moral turpitude and character for consideration by the board as well. We worked very closely when this was moving through committee with pharmacy board, PT boards, all the other healthcare boards, and had an amendment that Representative Kaler actually agreed to include before they passed out of committee. There was a last minute change. We did not receive the amendment, and it kind of sat there since February. It came up as a priority for the speaker last week. We re-engaged with House Caucus staff and the representative's office. However, they decided to move it out of committee without any changes. I believe this is one of the bills that they're just trying to get past that red line, so it's not sitting there. So what the board is going to do moving forward is continue to work on this from the amendment that was drafted, and we will engage the Senate when it comes time. The Senate will not be fast tracking this bill at all. We've already had conversations about what occurred in the House, so I wanted to make you aware of that. Are there any questions on this piece of legislation? All right, I'll take that as none. Moving forward, we have two pieces of legislation as well: House Bill 641 and House Bill 650. These deal with medical marijuana, autism, anxiety, and opioid use disorder. These two pieces of legislation essentially came from the Democrat caucus. And I know there was consideration from the Medical Marijuana Committee on these. However, I do not see these, from the conversations I've had, these pieces of legislation will not be moving fast anytime soon. The appetite in either chamber to move pieces of legislation that expand medical marijuana is very low. So these are more or less just statements from the Democrats. And I expect them to be sitting there for a while, but I want you to be aware that they're out there. Very short bills. Like I said, all they do is they add autism, anxiety, and opioid use disorder to the list of recommendations. Moving forward, we have Senate Bill 178, which is the podiatrist's flu vaccine bill. You cannot really give a flu vaccine to anybody under the age of 7. This is passing out. It moved over to the Senate, and they're going to be passing this out. It's a Senator Schuring bill. The board looked at this, and I had Dr. Saffron look at this as well. There doesn't seem to be any concern from the medical community. It's just greater access to the flu vaccine. Senate Bill 303 is the pharmacy consults piece of legislation. This one allows greater access to the pharmacists to consult with nurses and others to allow for greater access to patients when it comes to their medications. So it allows the pharmacist to work directly with it. But technically, he'll prescribe the medication if it's an APRN or PA, and allow to tailor that. I would assume this is the pharmacy board was on board with this, and so was a lot of the medical community. Does anyone have any questions about this piece of legislation? Portions of this were included in the amendment, so the APRNs currently were included as of the Senate floor. So we're going to be in GLIPS 203. So advanced practice nurses and physician assistants can manage drug patients currently, and I wanted you to be aware of that. House Bill.
Forgive me, Ms. Montgomery, were you raising your hand?
Yes.
Yeah, sorry.
I'm not sure. I don't have my documents in front of me. Did we take a position? I noticed in some of these cases, some of these bills that you're talking about, we've taken no position. And did we take a position on the pharmacist consult agreements that we were talking about?
No, I don't believe we did. We were looking. One of the things that we were going to do prior to the epidemic was create a plan to figure out how to properly engage and take a look at this, and that wasn't done. I did do the due diligence on the ground, and there was a lot of support. The hospitals came in and testified. The association, all the associations were behind it.
I'm not objecting to this. I just, as I look through a lot of the bills that it looks like we should have a point of view on, we don't seem to have taken a position. And I'm not sure, Mr. Chairman, whether we have created a policy yet on what the board, particularly the policy committee, how we work with our legislative liaisons to ensure that we weigh in appropriately not too often, obviously you have to have some balance, but that we weigh in on appropriate pieces of legislation rather than taking no position.
Sure. Mr. Gunadakis, you raised your hand.
To address Ms. Montgomery's point, historically, we have done that, and we've done it quite often. I personally sat many state reps and state senators' offices over the past 10 years being on the medical board, and it seemed like that has dissipated over the past 6 to 8 to 10 months or so. But historically speaking, just for a point of view, Ms. Montgomery, that was the practice, at least in the past. Why that's changed, I don't know.
So, Mr. Chairman, my only suggestion, because I do know that we heard, when I was in the legislature, we heard from the medical board regularly that I think we've talked about this, we really do need to figure out, and I think Dr. Soin almost said that, I think early on we need to have some kind of a policy about when we weigh in and how that process works, so that we're appropriately an appropriate voice at the appropriate time with policymakers.
Yes, Dr. Feigl.
Yeah, I agree wholeheartedly with that. And with regards to what Jonathan was talking about when we first started, I forget which bill it was, but the joint bill that we did with the other boards, it's disturbing to me that they would bypass what several of the boards would say. And a lot of that may be related to the fact that we don't have their ear, obviously. And I think something as important as that bill is, and the implication that would have to the board, we need to be as strong as possible on those kind of bills. And I know we took a position on that, but I do think that we need to have more of a presence on these types of issues as much as possible, and try to weigh in where appropriate.
Thank you. I think that's great feedback as well. Surely, I think we can work on mechanisms and methods to weigh in. So, some things we can talk about prior to the next meeting is, we could circulate some of the bills and stuff prior and have, people comment or even comment this portion of the policy committee meeting, or we could have Jonathan give us his opinion on if it's a bill that really affects us and if we, need to weigh in to protect our licensees or our citizens, and go that way. Surely, your message is loud and clear. We will make some proactive change. Don't know what that would look like at this exact moment. Sounds like Michael may have a suggestion or comment.
Dr. Soin, if I may respectfully, we used to do that. We used to get a regular memo. I can't say if it was weekly, bi-weekly, from Mr. LaCrosse on update on bills. And certainly just because a bill's introduced, it might not have legs, it might not be going anywhere. So we would have his discretion on what's important, what we need to weigh in on. So the point of me saying all this is we may not need to reinvent the wheel. We just need to go back and dust off some old policies we've had.
Yeah, but that sounds like really, I think we will be able to get back on that and do what we've done prior. I suspect this coronavirus and the disruption that's occurred may have, caused some disruption, but we'll be able to get that going at a minimum. Mr. Gunadakis. Any other comments? Mr. LaCrosse, more to report?
Yeah, just gotta keep, there's a lot of, we'll just keep trucking on through. And I thank you for the suggestions. Work with Stephanie and Jill and the board members to get a process going again on that. House Bill 484, the athletic trainers legislation. Essentially what this does, this bill was amended in the House I don't see the Senate moving this before they break. However, what this does is athletic trainers, it requires them to practice under collaboration agreements with physicians and podiatrists. There was an amendment that changed the definition. It tightened up their abilities, and it removed the athletic injury from a definition of athletic injuries. So this one will have collaboration with physicians and DPMs. So that wanted you. There's that one. House Bill 606 is the grants immunity to essential workers who transmit COVID. This is a tort liability piece of legislation that if a worker in healthcare who accidentally transmits COVID to a patient, they cannot be held civilly liable. There is. Just I'm looking at my list. Stuff I'll be in there.
I have one question about that bill, real quick. Does it also grant immunity? There was some talk about, and Stephanie and I were on a lot of calls about physicians being asked to do things out of their specialty. For instance, I was going to have to potentially, as an orthopedic surgeon, go to the medical floors and manage things that I'm not tremendously comfortable managing. Does this bill also grant immunity and from liability in those situations where we're acting outside of our preferred scope of practice to help in a pandemic type situation?
Yes, it would essentially fall under anything that came from from the governor's executive order. So if, as a physician, if you had to, like you said, if you had to go do somewhere in the hospital practice that normally you're not used to practicing under, it would qualify for that. Because I know you were seeing a lot of that up, like especially at the Cleveland Clinic, they were having where you're at. They were having physicians staff emergency rooms who had never worked in an emergency room a day in their life. So it would cover those.
Really?
All right, moving down the list, we have Senate Bill 1, which reduces the regulatory restrictions. This was a bill that has been out there for a while that they decided to dump some things related to COVID into. Essentially what this is, it required a rule reductions for cabinet level agencies. The board did not fall under this, so we did not qualify. However, they did amend in there that any governor's order has to go before JCAR. So essentially, after 14 days, the order will go through JCAR, and then the legislature would make that determination. So that's how that would affect our licensees, is that the legislature would have a greater say in that. And it's going to conference committee. I wanted you to be aware that bill's out there. There's a bunch of those floating around, as we've seen. Senate 1 and 308 or of the same kind. And then finally, we provided a last minute update on this as well to the board for the telemedicine piece that has passed. So this would be House Bill 679. There's a teleservices bill that was created by a working group led by Representative Butler. Essentially what this bill did, what it does is codifies the ability for practitioners to use telemedicine. It started out as APRNs, physicians, and those were the two that it went and it's expanded out. This was moving quickly through the House and became a priority under the Speaker. It was passed out of committee yesterday. It's going to rules of reference at 9:45 in the House today. So we provided a piece to the board members on what the amendment did. So I can walk you through what this looks like. There are two other parts on this that deal with Medicaid and also for the facility. It maintains the facility fee for using telemedicine. However, what I provided will directly affect the licensees and the board. It expanded the healthcare professionals that were eligible. It goes from all the way to a physician down to our dietitians who are also included in there. I know that the respiratory care professionals were attempting to be put in there, so I'm interested to see if they get in over in the Senate. They wanted to do minor management for things such as albuterol usage and others. But as of right now, there is quite an extensive list. The psychologists are in there, the clinical nurse, audiologists, occupational PTs. If you notice, their assistants are also in there as well. So the original piece had any supervised individual, so they did include supervised individuals for certain professions. The licensing boards, we must permit a healthcare professional to provide the telehealth services if they are listed. We are able to implement rules under this section under the 119. So when and if this passes, we'll work with the legal shop to figure out what those rules will look like and the board as well. The standard of care, they're allowed to use technology to provide telehealth services to a patient during an initial visit if it's appropriate standard of care that would equal an initial visit in person. So that's the standard of care that is put in this legislation. There's really no other. It just has to meet the same standard as an in-person visit. For treatment.
Can I interrupt you for a second, Jonathan? There is a comprehensive memo in your files that was provided to you. And this is actually, the telehealth is a little bit later on down in the agenda, where this bill was...
We're going to talk about that later. I skipped over the agenda. I'm sorry about that.
I'll just cover it now. So, so the bill moved really fast through the House. Unfortunately, we weren't aware OSMA was actually testifying last week. So OSMA provided testimony last Wednesday, and we think so. A lot of those sub amendments came from that OSMA testimony. You have their testimony loaded into Onboard, the sub-bill just came out yesterday. We haven't done a thorough analysis of that sub-bill. You do have an analysis of the as introduced bill, and we did pose a couple of questions for board discussion on things that we need some guidance from you all on. So that memo is in there. We can talk through those now, or we can skip to those later. But I did want to point out that because of the time of the bill, we have not done a thorough analysis of those of that sub-bill. I don't think it changes greatly any of the questions that we are actually asking for some direction on from the board. Jonathan needs that direction, so then that when we go to the Senate, we can talk about what sort of amendments we need at the Senate level.
For skipping ahead.
So I know this is agenda number 7 here, so I guess we'll handle it now. But what specifically are the questions that you wanted us to answer today?
Yeah, so I think what we really need to there are a couple. The first is relative to telehealth or to video for telehealth, and we would like to know if the board would like additional delivery means besides video for telehealth. Are there do we want to push for phone visits or email visits? Are there other delivery means besides video that we think we need to explore for telehealth?
By explore, do you mean restrict or leave in place or expand?
Well, right now the bill is worded as video only.
Mm-hmm.
Stephanie, one of the problems is we have an elderly population in Ohio that's really at risk. They're probably the greatest risk for the coronavirus, and many of them are not tech savvy. They don't have smartphones with cameras that are appropriate for video. They may not have computers with cameras that could be utilized. That's a problem we've run into in technology, and sometimes we have to revert to using just a regular telephone conversation, which is not as great as video, but it is a way to communicate to the patients. And I know that Medicare has allowed, at least during this crisis, reimbursement through Medicare for telephone conferencing. So there is a real vulnerable population, probably our most vulnerable population, that may not have access to a smartphone and camera. And so I think we need to really look at the vulnerable populations that may not have the technology, but still would require some type of telemedicine service to be able to be carefully managed. And allowing telephones might be one of those without the video or camera component.
Stephanie, I would also like to suggest that as well. We have quite a few individuals in southeastern Ohio who have very spotty internet service, and the telephone is the only way they're able to communicate. And it has been very helpful at my employment for us to be able to talk to patients via telephone. And some of them aren't comfortable doing video in terms of, showing their homes or whatnot. So I think it's very important that we continue to provide those services for economically challenged patients as well.
Thank you, Dr. Johnson.
I think you have 2 or 3 other questions that you want us to answer. So this is just a general comment. They may be moving this quickly through the House just to get the process working, because they've got such limited time that they're going to be in session. But I think it's really critical that we have a presence working with all of the affected allied health professionals that are affected by telehealth. This is just can be a remarkable expansion into folks who are not well served. And it'd be nice to be able to, it would be really important, I think, that we get the details right and the harmonization of House and Senate and other rules, because I know in Jonathan's memo to us, you've got inconsistencies in some of the rules or statutes that need to be harmonized, and then the speed and having on major bills, this happens all the time. But I think it warrants us making certain that we have a good working group among the folks who are affected to identify with the Senate that we want it right, but we want it fast, but we want it right. And so I hope that we will do that and make it a priority. And secondly, and Jonathan, you might be able to address this. And I haven't read your memo. I didn't see. The memo came in late last night, and I was working on other things, so I didn't see the last memo, so it might be addressed in that. There was some concern in the bill about a disparity between Medicaid and other telehealth, and we certainly don't want to have disparate treatment or inconsistent treatment or limiting the quality of medical care simply because somebody's on Medicaid. And I think you raised some issues there in your memo. And was that addressed before it in the House, or do we have to address that in the Senate?
I believe the sub-bill that was adopted addressed that.
I'm sorry?
The sub-bill that was adopted yesterday addressed a lot of those concerns.
So do you think that you'll be able to get a working committee with the Senate to, because this is really important. This is, if you want to have a Senate Bill 1, this should be Senate Bill. This is really remarkable if we can do it right. And we have other states, I assume the docs know better than I certainly don't know. There's other states doing telehealth, and I think having the input of our professionals as well as looking at other states with the Senate, maybe they will slow it down long enough for us to get it right.
That's what we're looking at and hopefully anticipating, especially with 2 physicians and a pharmacy practitioner, pharmacist over there. They've been a lot more pragmatic How this piece of legislation came to be was they pulled together a lot of the companies. Teladoc was one of them. We worked with Teladoc before. Smile Direct Club was one. And then the associations kind of came in on the tail end. OSMA provided a lot of the similar questions and comments that we had. So that's where that sub-bill came from. They fixed a lot. I called over and had that conversation with them as well. That we had the same questions. So we're hopefully that when it moves over to the Senate, we'll be able to get a working group going. Says there's limited time left, so that it might sit there for a while and give us that opportunity.
So I'm sorry to keep asking these questions, but we have on our docket a telehealth doctor today, and it raised for me, and I'm not a doctor, so it's very interesting to hear the commentary in the hearings. I mean, in our medical board meeting. If under telehealth, if I were being a doctor in Ohio, and I mean, is there a vehicle in which we end up expanding, for example, medical marijuana being where we wouldn't give it, but would be permitted because it's permitted in other states? Do you know?
Not that I've seen. Currently under the sub-bill, a practitioner can have that not only the continuation of care, but treat other patients in other states if that state's law applies for it. You generally are not seeing the ability to do that currently across state lines in certain situations. However, because generally we have to have a license in that state to practice, and that's where you see the conversations come up around the licensure. But I mean, potentially it could if that regulation dissolved. But right now they'd have to adhere to that state's laws and also our laws as well.
So thank you for that comment. And for the sake of efficiency, and Betty, I really appreciate your questions, but they have specific questions that they want to ask. So I would hope that the next people I call on specifically address the question of phone or email. I saw 3 hands raised in the order of Dr. Schottenstein, Mr. Ganadakis, and Dr. Feibel. So I'll turn it over to Dr. Schottenstein first, then Mr. Ganadakis, and then Dr. Feibel. Thank you.
Thank you so much. I was just going to say, essentially echo the comments that I heard about the phone, which is I have patients who are prone to anxiety about being on a video call. And just in general, in principle, I don't like the idea really of restricting a doctor's ability to consult with a patient on the phone. I think that doctors need to be able to have free-flowing information with their patients. And I think it's possible to go too far down that road of restricting that communication. And I don't think that would be healthy.
Thank you. Mr. Ganadakis?
I'll go quick. Generally speaking, this is a massive policy change for the state of Ohio if enacted, and I worry that we don't have a seat at the table in the legislature. Certainly we don't have it at the House, and getting a memo the night before our board meeting doesn't give us a chance to absorb this or digest it or be prepared for the policy committee meeting or what's to come after that. So I'll wrap it up with this, that we as a board, I'm not sure, have taken a strong position on this issue and other issues that are in the sub-bill here as described in the memo. So I think we have a lot of work to do, and we need to make sure that our voice is heard across the street.
If I may, Mr. Chair, may I interject just quickly?
Go ahead. Yes.
I do just want to, Mr. Ganadakis, I share your concerns, and I think that we do need to do some work to get some relationships going with the House that we're staying on top of things before we're hearing about them. I do know, again, as Ms. Montgomery pointed out, unique times that things are moving a little quickly due to deadlines and departure dates for the GA. But I think we need to take a really concerted effort on staying in front of the issues.
I agree with that. And something as big as this, this might even warrant potentially a special policy committee meeting down the road for this, so we can stay on top of it. We don't need to just do this once a month when these big bills do come up. As Mr. Ganadakis said, it does change the policy in Ohio. And I will tell you, after doing telemedicine for quite a while in orthopedics, there are specialties that are conducive to it and specialties that aren't as conducive to it. And it is helpful to save a patient from coming in a pandemic. But we need to be really thoughtful and careful about making it the new standard of care. And my fear is that there are going to be some people who very much take advantage of this, especially as we make it a telephone call system, because it's very easy to call a patient, check in with them for 5 minutes when you're doing nothing else, bill an office visit, and all of a sudden you've expanded your revenue but done nothing really for the patient. So I don't know how to put those safeguards in to make sure that doesn't happen as we add telephone, but video helps with that a little bit because it does require that extra level of complexity. And there were a lot of my patients that weren't able to do video, so I think you should have the ability to call somebody. But Medicare has significantly decreased that reimbursement, so that should not be parity level reimbursement as the bill suggests for a telephone call, except with maybe the exception of psychiatry, as Michael said. And I don't know how well you can separate those out, but I just think we need to be really thoughtful about what we're expanding here and really watering down what medicine is in the state of Ohio.
Agreed.
Michael? And just a final comment, I agree with that. I'm against phone or email visits. There are existing mechanisms that exist within CMS and insurance payers to compensate specifically for telephone encounters, and those should just be left in place and people could use those. Because then basically anytime a doctor would call a patient for a few minutes, they could bill. And also it flies in the face of two parts of the bill and conflicts with the facility fee. It seems strange that would be compensated the same as an in-office visit and the same as a video health visit. And secondly, it flies in the face of the liability waiver, in which case you're saying that physicians are held harmless for stuff that happens, that I saw in one of the memos of the bill, with portions of telephone encounters because they're not up to standard of care. And of course, I worry about opioids, although we do have separate rules to protect for that. You could put something in the bill that says something like, in the event that video is unavailable and that's documented, there could be a mechanism for telephone encounter, but they have to try video first. That's just my personal opinion. Stephanie, do you have other questions? Or Mr. Giacalone has a question.
Yeah, I just want to mirror what you and Jonathan said. I think the telephone piece, as Mark brings up, it makes a lot of sense with an elderly population, okay? That I can understand, but I think we need to be judicious in what we do with the opioid prescribing. While there might be roots, I look at online prescribing in the past, which was more beyond opioids. There's opioids, lifestyle drugs, and other things. I don't want us to fall back into that trap. And also even substance abuse. We don't, we're seeing this issue with Suboxone clinics, training out people that are just doing the Suboxone or, and not doing the program. And I don't want to see that happen again too. I think it does have a vehicle. I think telephone does work in certain populations and in certain specialties. I just would not want it to be universal, I guess, in that regard. That's it.
Stephanie, Dr. Freckle again, I think with the telephone conferences, we only do that at Ohio State only when the elderly patients have no means of doing video. Video is always the top way of communicating with patients, but there are some situations where it's impossible and the patients are ill, and the telephone may be the only way that we can communicate with them. So I agree the telephone would be something used when we can document that a video conferencing cannot be done. I also share everybody's concerns that the telephone can be really abused. It could be a way of generating income with minimal conversations. Patients could be billed for visits when it would be just a normal conversation on the phone that is part of our just daily work life. And it has tremendous potential for abuse. So I do think some documentation that the telephone would be used in situations in which it's important to communicate to the patient and evaluate them, but a video conferencing is not possible.
We've got I've got 4 more questions here, Steph.
Yeah, so I think we can consolidate some of these as well. But I think one of the things, at least, and I have not read the sub-bill thoroughly, so I apologize if this is covered in a sub-bill. Maybe Jonathan, you can address that. But when we read the initial bill, one of our bigger concerns was that our specific situations that set up parameters around telehealth for things like recommending medical marijuana, office-based opioid treatments, I think some of the weight loss rules have specific telehealth parameters and guardrails, and those are not in the initial bill, at least. And I think that, you know, our question is that something we want to make sure that we have the rulemaking authority to continue some of those specific situations?
Comments? Preferences for us to maintain autonomy in terms of making rules, particularly which place patients' harms and lives at risk. But are there other questions or comments? Okay.
Thank you. And then again, not sure if the sub-bill handled this or not. Jonathan, jump in if it did. But the initial bill, we had one in-person visit and at least one in-person visit per year requirements. Do we feel like those are adequate in-person requirements for the board? Does that change?
Change that language that an in-person visit can, the first visit can occur over the telephone as long as it meets the same standard of care as an in-person visit would initially. So they would have the ability to do that. And the bill does outline, say, if they were to use a telephone method, what that has to, they gave 3 points on what that standard is, and then if they use video, what that standard is. But the bill really just lays around that standard of care versus the visit. So that's where the determination of the board would have to come from. Does this meet that same standard?
Yes, Dr. Feibel.
Yeah, I don't think in most specialties that first visit can ever meet the standard of care of an in-person visit. So if you want telehealth, especially in a pandemic, we need to be very careful about the wording of that, because I can tell you my visits do not meet the standard of care of an inpatient visit, whether it's an initial visit or a repeat visit. I'm telling patients to push on certain areas to tell me if they hurt. It's very difficult to do. So I think the wording of that needs to be really carefully crafted, or you may prevent, especially during a pandemic like this, ever having a telehealth visit capable.
I strongly agree as well. Again, that first visit is critical for many things, not only physical exam, but, just establishing a solid doctor-patient relationship. I think there's that. That's really important. I understand weird situations like a pandemic or lack of access, and perhaps there could be some leeway there, but the general visit, I think it's important.
So I think that we've addressed, at least in some, the real questions that we issue spotted with the initial bill. And again, we need to really have a thorough analysis of the sub bill. I am concerned that we ensure that we receive the appropriate board feedback and direction as this moves. I do think, again, this is a pretty big policy shift for the state as a whole with regard to the delivery of medicine, and we need to have that seat at the table. I might recommend, Dr. Soin, and this is obviously your consideration, if we want to have maybe even a subgroup of policy folks who concentrate just on the telehealth that we can work with in between meetings, and then maybe come back to the board at the policy committee in July and have a bigger presentation on things that the board would recommend and take forward and work through the Senate.
100% agree. Really critical in this. Do we have volunteers to be on the subject?
I'd like to volunteer.
On the docket. Betty Monk.
Yes, Dr.
Okay.
I just want to make sure I got those. So we have Dr. Bechtel, Dr. Feibel, Mr. Ranadakis and Ms. Montgomery?
Montgomery, yeah.
Wonderful.
Dr. Soin, are you going to be on that as well?
I would hope to be on it if I can. Yes. That would be 5 board members, right? So we should be able to do that without an issue.
So what if a majority of the committee, though? Does that require notice?
Right. I think if you're going to have a meeting, you certainly you could do it electronically at this point, but I think you would need to give notice and have an electronic meeting and have a live stream available. I think you also can be individuals that staff can consult with, you know, on an individual basis without having a meeting. So I think those are the 2 options that you have.
Great. So we may start with individual consultations, and then if it's something that requires a more broader meeting, we'll go the route of a public meeting. That sounds okay with the rest of the group.
That sounds good.
Yeah. Yeah. So what I would greatly appreciate from that group is we'll get you the legislation from sub-bill, the comp doc, and then the overall outline. And then if you could provide comments, that'd be wonderful to me, at least so I know where each individual is coming from, so we can tailor from there.
It would also be helpful that and if you don't want to put and certainly not, you won't want to violate any of the open meetings law, put less than the majority of the committee on. And I think the group conversation is really important rather than just written conversations or individual conversations. So you can flesh out. You folks have so much experience on the boots on the ground realities that I think it's really important that you get together as well as just have written commentary. So if that would require one of us to step back, and I will volunteer because I'm not shocked. I've certainly been a legislator, but I think you need to get the group together and be able to talk openly without the public, so you can discuss frankly. So it seems to me you need to have a meeting that doesn't violate the rules or the law. And so if that, I'll volunteer to out.
That's great feedback, and I think we'll start with individual comments, and eventually we'll have a meeting and figure it out, and we'll certainly follow all the required rules and regulations. Thank you, Montgomery. Stephanie, do you have more comments on that?
No, I would just add, we'll make sure we include an issue spotting document with all of those materials to guide the conversation.
Thank you. Jonathan, do you have anything else in your report?
Yeah, there's just one more I'll touch on quickly. It was on my list. I popped over where we're going is the surgical attack bill, surgery system bill, House Bill 45. There was some concern about the scope and the registration. I worked with the sponsors. I gave them the comments that the board had in policy committee, and I talked to their lobbyists as well. And the associations and the hospitals agreed. They went and gave a sponsor testimony and said in the sponsor testimony as well, they're looking for full licensure. And moving away from the registration and allowing the board to, first off, writing the scope and allowing the board to properly regulate them as we do all of our licensees. There will be a sub-bill at some point in time. I wasn't given a time frame, but the bill will not be heard again until there's a sub-bill. So they're going to back up all of that and create a licensure, have the 119 and all of that in there for us as well.
Thank you. Dr. Seibel, I believe you have.
Real quickly, sorry. But on that bill, it says medical board position, none taken. I think we were pretty adamant in the policy committee that we had a position on that. So we just need to be careful about saying that we didn't take a position on a bill. And I think we need to have a position on this bill as well. Even if they're licensing them, we need to see what the merits are of that certification and whether it needs to be a separate licensure type of situation.
Okay. Thank you.
Thank you. I also agree. Thank you. So we'll move on to, I'm sorry, Dr. Schotten.
Oh, no, it's quite all right. I was just going to circle back to House Bill 492, the physician assistance bill. Jonathan, is there any movement on that? Okay,
No.
that's another bill that, along the lines of this conversation, I think we, going forward might be right to take a position on. It simultaneously waters down the qualifications of the PAs and also substantially increases their level of responsibility. It just, concerns me.
Yeah, there's supposed to be an IP meeting whenever that bill starts to move again. The PAs didn't let anyone know, from us to the associations to anyone, that bill was coming. They essentially dropped it. I had a conversation with their association lobbyists, and he said, we're going to have an IP meeting about it, and it's just been sitting there ever since. And from what I've been told from caucus staff, there's no intention to move it now. But I agree.
Thank you. If there's no other questions, we'll move on from the legislative update. And I have a suggestion for Kim as we move through the agenda. What I'd like you to do, since we do have to be cognizant of time, is to let's go over stuff that require action from this committee and vote. And if we run out of time, we'll just present those in my report at the meeting. So if you could do that for me, that'd be great.
Great, thank you very much. And I think we might be able to combine some things too. So first, we have two sets of rules that are ready for initial circulation. You have detailed memos on both of those, the hearing rules and exposure-prone invasive procedure precautions. There's some proposed changes in the hearing rules that were suggested from the hearing unit and from staff. And so we're looking to just send those out for initial comment. The other thing we want to do with those rules is we have a rule, the hearing subpoena rule, that's currently at CSI. And we've received some pushback on that rule. Working with the hearing unit, we made some changes to that rule that I think will be satisfactory to people. And so we'd like to withdraw that one rule at CSI and then put it into the full package of hearing rules for initial circulation. So that's your motion on that. For exposure-prone invasive procedures, there were just some minor changes made to that to include the respiratory care professionals into that set of rules. So if I could have a motion on both for initial circulation and to withdraw the one rule from CSI.
So moved.
Dr. Bechtel, thank you. Is there a second?
Second, Giacalone.
Mr. Giacalone, all in favor say aye.
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 Any opposed? Hearing none, that carries. Thank you.
Okay, great. So moving on, we have three sets of rules to file with CSI. We have radiologist assistants, personal information systems, and two dietetics rules. And you have detailed memos on all of that. We did not receive any comments on the personal information system rules. We received one comment on the radiologist assistant rules, and they did want to just let you know that I believe the statute around radiologist assistants addresses some of that informed consent issue because it does require radiologist assistants to wear a badge that identifies themselves as a radiologist assistant at all times and to work under supervision of a radiologist. So I think that may address some of the informed consent issues. The comment that we received was very cursory and not giving us a lot of detail on what that was about. So I'm recommending that we file with CSI as is, and then there will be a 2-week comment period. And then you have a detailed memo on the dietetics rules. Nate Smith can answer questions if you have any around that. But what we're seeking is approval to file all these rules with CSI.
I can make a motion to file.
So moved.
Yep. Great. And Ms. Montgomery, second. All in favor, say aye.
Aye.
And hearing no opposition, we'll move on.
All right, great. Thanks very much. So in the CSI updates, the only one that you need to take an action on is Rule 4759-602. And I'll let Nate address that with you. That's the one that we are seeking an action.
Thank you. This rule was actually ready to be filed with JCAR in the fall of 2019, and that Senate Bill 221 became effective. That made some changes to the requirements for incorporation by reference, which basically means the rules referring to external documents, and it required such things as the date for what version of the external document, and that it be posted on the website. So we noted some deficiencies in our external references when we were about to file this rule. And so this rule is coming back to basically correct these incorporation by reference issues. And in addition, we have, I believe, added an enforcement mechanism in the last paragraph, subsection O, because there's quite a few requirements in this 4-page rule, and there was not any kind of enforcement mechanism. So this would make it a violation of these, would be a violation of minimal standards of care and the appropriate subsection of 4759.07. This was taken back through the Dietetics Advisory Council on Monday, and they recommended approval by the policy committee to file with CSI. Happy to answer any questions if there are any.
Okay, seeing no
We
questions.
could have a motion and a vote. Yeah.
Motion to file.
So moved.
Second, Jacqueline.
Yep. Thank you. All in favor, say aye.
Aye.
And hearing no opposition, we'll move on.
All right, thanks. I'm going to skip over microneedling, and I'm going to go to the updated death certificate position statement. So in some of the questions that we've received, we discovered that this was a position statement that had been on our website and for some reason disappeared from our website. So when we looked at it, we wanted to update it and make sure that all of the rule references and statutory references are correct, which we did. And also we added a statement particular to death certificates related to COVID. There's a CDC guidance on that. And so, so we added that to the position statement. So I'm just looking for approval of this updated position statement to put on our website.
So moved.
Second.
All in favor, say aye.
Aye.
Thank you. That carries.
Thank you. All right. The next one that I would like to talk about is the weight loss rules, frequently asked questions. So we learned that Belviq, which is a controlled substance for chronic weight maintenance, I believe, was withdrawn from the market. And so there were two drugs, Qsymia and Belviq, and they are addressed in our rule 473111-041. They're not addressed by name in that rule. So the rule is working its way through CSI, and we don't need to make a change to that. But the frequently asked questions, you have in your packet that there was one question that did reference Belviq. So we would just like to take that reference out. So that will be updated on the website with the reference to Belviq omitted.
Does that require a motion?
I think so, yes.
So let's have a motion to remove Belviq.
So moved.
Or second, Jacqueline.
All in favor, say aye.
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 That might be. Thank you. That carries.
All right, thank you. So I'll come back to microneedling, and I think that we can plan to have a more robust discussion about this next month. We wanted to introduce the issue to you. the cosmetology board recently, I guess in December of 2019, made some changes to their rules for cosmetologists and estheticians, where they just clarified that devices like microneedling and cool sculpting are not permitted in the scope of practice for cosmetologists and estheticians. But then they did provide us with information that they're not opining as to whether those use of those devices is a medical task that can be delegated under the board's delegation rules, or a medical procedure that cannot be delegated. And it would have to be completed by a practitioner where that is in their scope of practice. So I did send some information and talk with Dr. Bechtel, and I think his initial thought is that this is a medical procedure and not a medical task, because there is risk of harm to patients who undergo the microneedling process. And we are also doing some research, legal research around other states to see how other states are handling this. So far, our consensus, the consensus seems to be that other states do consider microneedling to be a medical procedure, but we have not seen that other medical boards have weighed in on this particular thing. And so, so we want to keep doing the research, and I think keep getting information from practitioners. And I don't know, Dr. Bechtel, if you had any comments.
Well, I think what's involved there, it's sort of platelet-rich perfusion, where blood is drawn out of a patient, spun down in a centrifuge, and then injected into areas of like acne scars or into the scalp to stimulate regrowth of hair. There's risk of course, of bleeding, infection. There's been reports of nerve damage. Recently in New Mexico, the blood was mixed up and patients were potentially exposed to bloodborne pathogens such as hepatitis C, HIV, and there had to be extensive testing done of a large number of patients. This was in New Mexico. So there are risks involved, and again, to delegate this to a non-licensed person concerns me. Cosmetologists specifically in the Ohio Revised Code are not allowed to do microneedling. They said in the rules they're not allowed to penetrate through the epidermis to dermal tissues, and actually specifically in the rules they cannot do microneedling. So the only way they can do that is if they're considered an unlicensed person, and because they're not licensed in that setting as a cosmetologist, they can do the procedure. But I have a lot of concerns about potential complications, and especially when you're working with blood products, contamination, and things like that.
Dr. Bechtel, I had a question. Are estheticians licensed, or does anyone know how they're licensed or regulated or certified?
I believe they're licensed for cosmetology.
Mm-hmm.
Okay.
Right.
And then what about cool sculpting? Because I think that was mentioned, because I know a lot of different places or spas, you see ads for it and things like that.
I believe in the rules and regulations they're not allowed to do that either.
Yeah, that's correct. Cool sculpting was also included
Okay,
as being outside their scope. Mm-hmm.
For estheticians and cosmetologists.
Yes, that's correct.
Okay.
So, Ken, just to clarify, and maybe Mark, if you're in a physician's office, they can delegate it to a non-professional to do this? Is that what I think I've heard?
Well, that's what the debate is. Can a physician be allowed to delegate that to an unlicensed individual to perform the procedure?
Okay.
The revised code specifically states that a cosmetologist cannot do that.
No, agreed. I agree with you. But in a physician's office, too, that can or cannot be delegated. That's my question. But I'm hearing you're saying no, cannot be delegated, or can?
Well, that's where the debate is right now.
I think that's where the debate is.
Okay.
So under the medical boards, so I think what we're saying is microneedling and cool sculpting are the practice of medicine. Then it becomes, are they medical tasks that can be delegated to unlicensed people under the board's delegation rules, or is it a medical procedure that can't be delegated? And that's kind of the crux of the question.
Okay. Well, I think this seems to be a no-brainer, listening to Mark and just what those envision. I mean, this isn't like laser hair removal or any other stuff. This is way more complex. I think this is no, this isn't a delegated event.
Yes, Dr. Schottenstein.
Thank you. This is reminiscent, I think, of the conversation that we had about the massage therapist who wanted to work under chiropractors and do like the ultrasound, right? And so I guess, fundamentally, this sounds like a scope of practice issue. And so I think we need to sort of keep that in mind along with possible antitrust issues that might come up through our dealing with this matter.
Yes.
Feedback.
I'm really not looking for a decision today. I wanted to introduce the topic and the question, and I think we'd like to bring it back to a future policy committee meeting.
Great. So thank you, all of us here. Something for us to digest and think about, and then we'll be back with more robust opinions after we've had time to reflect. If there are no other comments, I believe that concludes our agenda. So is there a motion to adjourn?
So moved.
Thank you.
Second.
Thank you, Ms. Montgomery. Okay, and we'll see you all in the.
So we went a little. I was thinking 10:15.
Can we have a voice vote on the motion, please?
Oh, sorry. Yes. Yeah. Aye.
That'll work. Thank you very much.
Did you guys want to get started at 10:15 or go 10:20 since we're a little over?
I believe Tessie pushed it until 10:30.
Oh, that's that then.
Oh, okay.
So see everybody at 10:30, huh?
Okay.
Thank you.
Bye, everybody.
Bye.
Bye.